So I'm Juan Pablo Frias. I'm Chief Medical Officer of Biomea Fusion. I'm an endocrinologist and diabetologist. And great to see actually so many people here. Steve and I were just commenting for Saturday morning. So really appreciate your interest in you being here at this symposium. And I'm joined today by my good friend and actually my fellowship director from 25 years ago, I think, at UCSD. Dr. Steve Edelman, who founded and is the director of taking control of your diabetes. He founded this patient-focused organization, does a lot of physician education as well 30 years ago. He's a professor of medicine at the University of California, San Diego. You see his many accolades below there. And Steve's disclosures are that he's had type 1 diabetes since age 15, so just a few years. And he's a consultant. He's on our scientific advisory board, and also joined by Rohit Kulkarni, who's a physician scientist and researcher at the Joslin Clinic at Harvard Medical School. You see Rohit's many accolades there as well, and he actually is the chairman of our scientific advisory board at Biomea. So we've worked quite closely with both of them over the years. So here's our agenda. I'm going to give just a brief introduction to our company, to Biomea Fusion, and then talk a little bit, just briefly, about icovamenib, which is our oral covalent menin inhibitor that's in clinical development for type 1 and type 2 diabetes. Steve will be speaking about heterogeneity in type 2 diabetes. We all know that this is a very heterogeneous disease, and as you'll see, given our mechanism of action, we have very nice efficacy, particularly in those patients with severe insulin deficient diabetes. So patients with type 2 diabetes who are very insulin deficient, but also you'll see in combination with GLP-1 based therapies in patients who are more insulin resistant as well. Rohit will go over some of our preclinical data. We have quite a bit of data in human islets and islet microtissues, as well as in animal models. And then I'll top it off by presenting the top level result of our phase 2 study in patients with type 2 diabetes. This is a 52-week study, but the primary endpoint is at week 26. And I'll show the A1C data. And for the first time, we'll show our C-peptide data as well. So without further ado, we'll get going. So Biomea Fusion, we're headquartered in Redwood City, California, which is in the Bay Area of California, close to San Francisco. The company was founded in 2018, and we see the two co-founders on the left, and they're standing in the back there, Tom Butler and Ramses Ertman. And Tom has been involved in drug discovery for many years at Gilead, at Pharmacyclics as well, and he is a co-inventor of icovamenib. He's a medicinal chemist, and we have a team here that's very experienced in drug development. And we work together great, and we're here, we have a booth, and we'd love to meet you outside of the confines of this symposium as well. So let's talk a little bit about menin. Menin is a scaffold protein. It's a nuclear protein that regulates many physiologic functions, but plays a very important role in glucose homeostasis. And in fact, it's a negative regulator of beta cell proliferation. So in a sense, it puts the brakes on beta cell proliferation. So inhibiting menin enhances insulin secretion through two key mechanisms. One is proliferating beta cells, so increase in insulin secretory capacity, but also we found that it increases, that is the inhibition of menin, the expression of GLP-1 receptors. There's also work that has shown that it increases GLP-1, the protein itself, expression and protein levels. So icovamenib, and you see the characteristics here, is a covalent small molecule menin inhibitor. So it's given orally. It's been very well tolerated to date, and I'll show some of the data from our type 2 study. Given its mechanism of action, it's complementary to all other anti-hyperglycemic agents in diabetes. And very importantly, it's non-chronic with respect to its dosing. So our early studies, we dosed for 4 weeks and had follow-up at week 26. And what I'll show today is 8 and 12 weeks of dosing. You stop icovamenib, and we're looking at 26 weeks, and we'll have 52-week data towards the end of the year. And again, the mechanism of action, which Rohit will go over very carefully with our islet work and our animal work as well, is that it increases beta cell mass and function, and also what I mentioned about the increase through menin inhibition, the increase in GLP-1 receptor expression. So both very important. Now, what we're doing really is harnessing what happens in physiology. And this is work that goes back, this is from Stanford. It was published in Science almost 20 years ago. So this is in 2007, 18 years ago. And what was shown in these animals, and this has been replicated in other studies as well, is that during pregnancy, which as you know is a state of increased insulin resistance, prolactin is increased, the pituitary hormone. Prolactin actually has an effect to inhibit menin. And through this menin inhibition, there is then proliferation of beta cells, increase in beta cell mass, and increase in insulin secretion, which compensates for the insulin resistance, maintaining euglycemia. So what we're doing with icovamenib is in a sense sort of harnessing or mimicking physiology. This also occurs in obesity and other states of insulin resistance. My last slide just goes over our pipeline. So again, we mentioned icovamenib, which is seen on the top. I'll be reviewing data from Covalent 111, and this is a phase 2 study I mentioned. We also have an ongoing study in patients with type 1 diabetes, and we should have data towards the end of the year, some preliminary data in those patients as well. And then if you look on the bottom, we do have an obesity program as well, and we have an oral small molecule GLP-1 receptor agonist that's in pre-IND or IND enabling studies now. We anticipate having that in the clinic for first-in-human dosing towards the end of this year. So quite a bit going on with respect to diabetes and obesity as we move forward. So now I'll turn it over to Steve to talk about the heterogeneity of type 2 diabetes. Steve?
Thank you. Well, thank you, Juan. And I'm excited to go back in time and talk about a topic that we did speak about frequently in the old Ralph DeFronzo days when we really did not have too many different medications to treat type 2 diabetes. Okay, let's go forward. So you've seen this slide. This slide used to be shown at every talk, at every conference, is the ominous octet. And it's interesting that the very initial slides that we used just showed the liver, it showed a pancreas and skeletal muscle. That was it. And then as new defects were discovered, pharmaceutical agents were designed to address those targets. Now, front and center, as you can see, is insulin secretion. That is something that really is important when we think about the heterogeneity of type 2 diabetes. And this is an old slide. I love it. If you look at the date on there, I had to get out my 35 millimeter slide, scan it, make it into a slide. And this is an important slide. You can have a whole conference on this one slide because there's so much heterogeneity to type 2. There's also things change over time. So in the early stages, people are asymptomatic. They have family history of type 2 typically. Insulin resistance comes in. You can see it up here. I'll get my little pointer out. And up here. And insulin resistance pretty much stays the same over time, unless someone increases their weight quite a bit or gets some other condition that causes insulin resistance. But there is compensatory insulin secretion. You can see that in red. And then people are typically diagnosed when the blood sugars are through the roof. And I'll show you some data from the UK PDS study. We learned quite a bit from that study. And then over time, you have beta cell loss. So we always talk about the endogenous insulin secretory ability of your patients with type 2 in clinic, and that dictates sometimes what drugs they're going to be successful on. And then, of course, there's people develop macrovascular disease long before the diagnosis. And then, of course, microvascular is a result of the duration and severity of hyperglycemia. And of course, this slide came from the UK PDS study, and I believe Ralph DeFronzo was one of the ones that showed this slide, that by the time people are diagnosed with type 2, they've lost 50% of their beta cells. And that's one reason why people need more than one therapy, typically. And in systems where individuals get extremely good healthcare, executives like Tom Butler, they get a whole history and physical every year, and then they can pick up diabetes early. And then if you institute therapy, preventative therapy, they can go a lot longer before they need something that perhaps insulin and other agents. So this is just a cartoon slide that talks about the heterogeneity of diabetes. And I want to show you a short video. As Juan mentioned, I have a not-for-profit organization. Before COVID, we put on large conferences around the country, and we inspired people. We educated and motivated them. And you're going to see a large group of people. And I always tell them at the beginning of the day that at the end of the day, you're going to be so motivated. You're going to be happy you have diabetes. So here's a short video. I'm just going to show you a couple seconds of it and what it looks like to have 1,500 people happy they have type 2 diabetes. Most of them type 2.
1, 2, 3.
Never thought people would be happy they have type 2 diabetes. All right, well, let's go on. Now, this is an interesting slide, especially for someone like myself, who I would say with all the excitement in type 1, hybrid closed loop, islet cell therapy, the attention of type 2 isn't 100% anymore. And you can see on this slide that, when we diagnose diabetes, if you think about it, type 1, type 2, gestational, we just look at glucose at these artificial levels. But those types of diabetes are markedly different. And even within the type 2 area, you can make certain subgroups. So if you look over here on the left, the data has been out for years. And for me, it was quite interesting because you can take these basic demographics and also lab data, the A1C, weight and age, pretty standard, important features to characterize your type 2, and then HOMA B and HOMA IR. And as you know, these are calculations, and we have the hardcore investigators that say, "Oh, I don't believe it. I don't like HOMA B." I call them homophobes, but and if you look and you separate out and you can define these groups, and you can see what kind of percent are more prone to insulin deficiency. And that's obviously severe insulin deficient diabetes and the mild age-related diabetes. Now, I'm not going to get into the details of each group, but when I first saw this, I said, wow, you can make a little song on this, the MID, the SID, the MARD, and I think it's better just to be descriptive. Now, on the left is a paper that was put out in Lancet that talked about these subgroups, and I would encourage you to get that paper and read it if you're interested in how they identified these subgroups. And in the middle, you can see that there's obviously overlap, and it would be very unusual to have distinct groups of those 4 groups. And on the right, just like you can put your age, your weight, and your height in the computer, and you can calculate your BMI, just like when you're looking up liver disease, the FIB4. And there are online calculators where you can determine which group your patient may be in. Now, further to fine-tune the subdivision, there's 2 core drivers: insulin deficient diabetes, and you can see the 2 groups, the one that's fairly well said, which is severe insulin deficiency, but also mild age-related diabetes. And you can look below, and you can see that the HOMA IR is not there, and the A1C is there, and the BMI is there, and the HOMA B is there. And you can see that on the group on the left, the severe insulin deficient, they have the highest A1C. And this data was taken 4,000 patients from the ADOPT and the RECORD trial. To spark your memory, the ADOPT was one of several studies that was done, multi-center study in the United States, looking at does tight control prevent microvascular complications. And they had a very good database. I was involved in the VADT trial, which is very similar. And then you can see the mild age-related diabetes. And you can see that the A1C is higher in this group, and also the BMI is lower than the 2 on the insulin resistant side. And so I think for any of you that see patients in clinic, this may strike a bell in some of your certain ethnic groups that are thinner, but have insulin resistance, and they may not do that well when you treat them, and they march down the natural history of drug therapy as well. And so this, going back to the 4 subgroups, and this was a study done in a EMR in China, where they had over 2,600 patients. And you can see the percent in each group in this database. And it's fairly similar to the group in the prior set of patients that I showed you. And on the right, you can see that in the group that had severe insulin deficiency, the A1C was highest. They had, you can see their rate of retinopathy, which relates to microvascular disease, obviously, and poor glycemic control. And on the bottom, you can see the mild age-related diabetes where the coronary events are actually the highest as well. So there are other countries that probably are more interested in these subgroups than we have typically been in the United States. Now, if you look at the Japanese consensus statement, how to treat patients, I'm not going to expect you to read that, but let me blow it up for you. And it's interesting, they subgroup their patients into non-obese, which is typically, as you can see right below that, more insulin deficient, and those that are obese. And they actually recommend different therapies based on these two categories. And I just sort of highlighted, they're talking about insulin secretagogues there, and probably insulin. And the group on the right, their recommendations are pretty far behind us in the States, but they talk more about insulin, things like GLP-1s, SGLT2s, and things like that. So there are, there's precedent to look at the different subgroups. And I really like the way the folks at Biomea made these 4 subgroups, and it really helps you focus in on how you design your clinical trials. Now, this is a slide that is near and dear to my heart. I'm very interested in adherence and persistence in type 2s. And if you look at the drugs that have been approved in the United States since 2005, there are a ton. Now, each one of these do not represent an individual class. Obviously, there's 5 SGLT2 inhibitors, throughout the world. And there's, DPP4s, there's insulin sensitizers, GLP-1s, and there's been a lot. But when you look at, did that make an impact on the number of patients with type 2 in the United States who reached an A1C less than 7? No, it did not. So this is NHANES database. Now, you can see that this data has been updated, but I can tell you that the percent of people reaching an A1C less than 7% with type 2 in this country has not changed, despite the development of, TZDs, SGLT2s, GLP-1s. That's kind of shocking. And obviously, if you look at all the factors that lead to coronary artery disease on the right, it's even more shocking. And there was a let me just show you this slide. This is one of my favorite studies, done very well by a pharmacy, scientific and academic pharmacy group on the East Coast. And prescriptions are not always filled, taken properly, or refilled as directed. And if you look at, out of 100 prescriptions written, only 50 to 70% ever make it to the pharmacy. If for those of you that see patients, you say, gee, I prescribed this last time, they say, oh, I didn't pick it up, I didn't call and didn't send to me. 48 to 66% leave the pharmacy, 25 to 30% are taken properly, and a small percent are refilled. And there's so much data on this. And the problem really is adherence. And I can talk about this all day too. Adherence has a specific definition. A patient may have a particular drug that you have prescribed in their possession 80% of the time. So they still could miss it 1 out of 5 days and still be considered adherent. And there's no guarantee that they actually swallowed the pill or took the injection. So there was a paper I did with Bill Polonsky using a large administrative claims database looking at adherence and persistence. And we realized that when you look at the data in clinical trials, it looks pretty darn good. But when you get out to the real world, the A1C reduction as one of the primary endpoints just doesn't look as good. So in this study, we looked at people who were on once weekly exenatide in clinical trials. And you can see at that time, certainly not as good as the GLP-1s we have today. They had a typical, out of 4 phase 3 clinical trials, they had a mean A1C drop of 1%. But when we looked at those patients who had been on those same exact drugs, very similar demographics, for 1 year, the A1C drop was 0.5%. So we called that the efficacy gap. And then when we analyzed what made up that gap, 75% of that gap was due to adherence. And because these patients all had insurance, we knew we had refill data. And persistence is another definition, but it's primarily adherence. And my own personal belief that adherence in type 2 is one of the single greatest headwinds that we have to improving diabetes control in this country. There's no sense of urgency with people with type 2. They don't feel that bad if their A1C is 13%. And they feel good if they feel fine if they take their medications or they don't. They have copays. It's expensive. Type 1s are different. We have a huge sense of urgency. I don't take my insulin. I'm going to feel pretty sick pretty soon. So icovamenib is a very interesting compound. I've been learning more about it, hanging out with Dr. Frias and my other friends now from Biomea, going to several advisory boards. And it's an oral medication. And if you cut to the lower right, as Dr. Frias said, you take it once, and then it has a prolonged effect, covalent binding, and that's quite amazing to me, and that would help address the adherence and persistence issue in many patients who have a problem taking drugs and refilling drugs. In the lower left, these drugs you can use with any other drug. There's no reason, data to show that it would not be effective in combination with every drug on the type 2 market, but it's exciting to know that there may be some special effects with the GLP-1 pathway. And in the upper right, it's well tolerated. So it has some clinical benefits, at least to someone who's in clinic here and there and teaching, that may be very beneficial. So this slide is really meant to say that this is important when you look at the beta cell. And we might be able to bring back some beta cell function in people with type 2 diabetes, because we know their beta cells are not totally gone, like many patients with type 1. Even in people with type 1 diabetes, with the assays improving for insulin, that we see that even people with type 1 of long duration still can secrete some insulin. And perhaps icovamenib could bring back some of those beta cells and revive some insulin secretion. Okay, I think that's it. Rohit, you want to come on up?
Thanks very much. My name is Rohit Kulkarni, and I'm delighted to be here again, excited to be part of the Biomea effort here to understand a little bit about how we can make more beta cells. So let me step back from what Steve was talking about and tell you a little bit about some of the physiological components and the mechanism of action of how this might be working. But just to give you a little bit of the preface of why I'm here, I started working with Biomea as an advisor for many years, and I'm as excited today as I was many years ago because making more beta cells or trying to make replenishing the beta cell pool is a major component of treating patients with type 2 diabetes or type 1 diabetes. My lab has been doing that for the last 25 years, and I'm really excited that we have found this particular molecule which has a role. So shown on this panel on the left is how menin could be involved, as Juan Paulo just mentioned. Menin is a scaffold protein in the nucleus, and you can see that it has a number of proteins that it can interact with. Overall, when menin is normally present, the beta cell proliferation pathway is off. But there are some components or some physiological and pathological states, early pathological states, where this can be altered. Pregnancy is one of the classical ones where you find that menin is blocked by prolactin in the normal physiological state during pregnancy. Now, this is extremely exciting because in the normal situation, when menin is not blocked, the beta cell is in a static state. There's no proliferation of beta cells. We know that the doubling of the beta cells is about 5 to 8 years. But in pregnancy, because of this added component of the offspring, because of relative insulin resistance, the beta cell has to compensate. It has to increase secretion, and that is done by a natural phenomenon where prolactin goes and blocks menin, and that releases the brake on the beta cell for a short duration of time that allows the beta cells to increase secretion, and it absorbs the insulin resistance. So this is a classical mechanism by which menin is blocked, and that can lead to enhanced proliferation. Now, this can also be seen in other states, in early scenarios where you have either hyperglycemia or high-fat diet, the PBK1 pathway here and potentially the PKC-AKT pathway, both of them inhibiting menin. And both of these components, where the pathways which inhibit menin, leads to the machinery being turned on to allow beta cell compensation. So in early stages of hyperglycemia, high-fat diet, there is a compensation by the organism to overcome the insulin resistance. And for this, you need to enhance beta cell secretion and beta cell proliferation. So you have one physiological state and a couple of pathological states during the early occurrence of beta cell proliferation and beta cell mass increase. So this, we think, is remarkable because if you have a small molecule which can do this in vivo in patients with diabetes, that will be remarkable in the context of enhancing beta cell growth and secretion. So let's look at the human islet data in this context and how icovamenib is able to work and enhance beta cell growth. So shown here is a study undertaken by my colleague Dr. Balakrishnan at Biomea, where they've taken cadaver-derived human islets, and they treat these islets for 1 week, 2 weeks, or 3 weeks with icovamenib. Or you can treat them with 2 weeks and then you have a 1 week washout to look at what happens over a prolonged effect of the icovamenib. So shown at the bottom is one such example where you have the donor characteristics here on the left, and you can see that the two distinct experiments, one with standard glucose and one with high glucose. The other thing to remember is we also use a compound called harmine as a positive control. So there are a couple of important messages here. Under standard glucose conditions, there is no effect of icovamenib. You do see some effect of harmine, which is the positive control. But when you increase the glucose to a high glucose level, after 2 weeks of treatment or 3 weeks of treatment, you can see that icovamenib has an increased effect on beta cell proliferation, as shown by EDU positive, NK6.1 positive as a percentage of the total NK6.1 percentage cells. These are acronyms for transcription factors, and those of you in the field will be aware of that. After the washout, icovamenib has no effect, suggesting that it has an effect over a period of time. You take away the drug and it has no effect. And you can also see that harmine does have an effect as a positive control. So the take-home message from here is that in vitro conditions, take human islets treated with icovamenib has an effect only when the glucose is high, as you would see in patients with type 2 diabetes. So let's look at this in a little more granular level, right? So you can see that this graph here shows again the percentage of proliferating beta cells, 1 week treatment, 2 week treatment, or 3 week treatment. Again, harmine is your positive control. And what is shown here is the number of percentage of the beta-like cells at different concentrations of BMF-219, 0.7, 0.075, 0.15, and 0.3 micromolar. You can see a nice dose-dependent effect. You can see that the harmine, which is a positive control, has an effect at 1 week. It has toxic effects and loses its effect over a period of time, but not icovamenib. The second take-home message from this is the number of islets which are proliferating, which is shown with this red circle in each one of these graphs, keeps reducing. So 3 weeks, you can see almost all the islets showing positive cells compared to 1 week. So it suggests that this duration of treatment is allowed to recruit a number of these beta cells to begin to proliferate over a period of time, leading to enhanced beta cell mass and secretion. So can we also look at this in the context of GLP-1 treated therapy? So that is the next experiment that was done by the group at Biomea. So let me give you a little bit of the background of this, right? So here, shown here is two graphs. Shown on the left is how, in the context of GLP-1 and menin, how it modulates the beta cell biology. So shown on the left is how menin promotes glycemic control in the context of GLP-1 action. So the take-home message here is that menin is linked with PRMT5, which is an important protein involved in the regulation of GLP-1 receptor expression. And in a normal situation, menin is linked with PRMT5, and that prevents the GLP-1 receptor expression. So this represses GLP-1 receptors in the off and is in the off state. But when you add icovamenib, which blocks menin, this releases PRMT5, which then initiates GLP-1 receptor expression into the on situation. That leads to enhanced GLP-1 receptor expression, phosphorylation of CREB protein, enhanced pro-proliferative genes, and insulin expression. So you can see that this is the second component. Menin enhances beta cell proliferation on the one hand. On the other hand, it interacts with PRMT5, and when menin effect is blocked by icovamenib, that leads to enhanced GLP-1 receptor expression and the attendant effects of GLP-1 receptors, enhancing insulin expression and enhancing pro-proliferative genes. So this is a very important observation we feel because it's got the second mechanism of action of menin. So can we show this by other ways? Yes. So you can do an experiment where you go back to the cadaver islets and you treat them with icovamenib with 3 different concentrations, increasing concentrations, and see what happens in the context of glucose-stimulated secretion in the presence or absence of tirzepatide, which all of you are very familiar with, the GLP-1 GIP receptor dual receptor agonist. Shown here is one such experiment where you see insulin secretion in the absence of tirzepatide and in increasing concentrations of icovamenib in the presence of 30 nanomolar tirzepatide. You can see this nice increase in insulin secretion, almost doubling the effect of secretion without tirzepatide. So you can see that here the ability of icovamenib to engage GLP-1 receptor expression and enhance the effect of tirzepatide, arguing that perhaps this would be a nice way to have an adjunct therapy for enhancing secretion of insulin. You can do this with other compounds as well. For example, you can take orforglipron or BMF650, which is one of the GLP-1 receptor compounds produced by Biomea. And again, you can do a similar type of experiment where you have increasing concentrations of icovamenib in the presence of increasing concentrations of orforglipron or BMF650. In each of these, you can see there's an increasing concentration of glucose-stimulated insulin secretion. So these argue that perhaps you can link BMF209, icovamenib, with other components which are involved in GLP-1 therapy to enhance secretion of insulin. And you can make this even more granular by looking at the individual donors. So many of you are wondering, oh, that must be just one specific donor, but here you have 8 different donors where you looked at the effect of GLP-1 receptor or insulin expression. You can see that some of the individuals show an effect and some of them show enhanced effect. And this could also translate in real life, right? Some patients may show a lower effect and some patients more dramatic effect. So maybe you need to have an effect for a longer period of time to bring up the others to having an enhanced effect. But this is the variability that you see. And this can also be shown at the level of protein. So you can see there's a plot showing 2 different donors where again to do the same experiment, icovamenib, GLP-1 receptor expression of the protein level is increased and shown here at the molecular weight of 57. What about insulin content? So here you have shown the effect of proliferation. You have shown the effect in the context of GLP-1 receptor having additive effects. What happens to the insulin content within the beta cell? So that can also be shown by the experiment here. You can culture these islets over a period of time and look at the insulin content. Again, you can see the 2 different donors showing an enhanced effect in the presence of icovamenib. Again, this is variable between individuals. You can go back to the earlier studies that were done in Sphero. You can show that in the context of high glucose, but not standard glucose, the amount of insulin goes up at day 14 and day 21. So you can see that orthogonally, multiple types of experiments show the similar kind of effect of enhancing insulin content in addition to increasing insulin secretion and proliferation. So finally, you can do some experiments in vitro. I'm sure many of you are thinking, oh, what happens in vivo? But before you do an in vivo experiment in humans, you have to do these experiments in rodents. So shown here is one example where you can look at the GLP-1 based therapies in vivo. So shown here is an example of the study where icovamenib has been added on to a low-dose semaglutide in the ZDF, Zucker-diabetic fatty rat model of type 2 diabetes. So shown here is the experimental plan where you have group 1 where the rats are treated with a vehicle for 14 days, followed by semaglutide for another 14 days. In group 2, this is preceded by icovamenib treatment for 14 days, followed by icovamenib in the presence of semaglutide. And then you have the readouts of C-peptide, blood glucose, HbA1c, the HOMAs, and body composition. And here is a series of data. Let me go through that a little bit slowly. You can see that in the context of fasting blood glucose, HbA1c, compared to the baseline, there is some effect of the black bar, which is the vehicle with semaglutide. But look at the green bar, which is icovamenib with semaglutide, showing a dramatically better improvement in fasting blood glucose. This is reflected by improved HbA1c. You can also do an oral glucose tolerance test and look at the area under the curve. You can show a dramatic improvement in the presence of icovamenib in the context of treatment with semaglutide. And this also in the context of C-peptide index, a stimulated C-peptide showing a very dramatic increase in C-peptide compared to vehicle with semaglutide alone. And these are also reflected by HOMA-IR and HOMA-B. But though overall, the in vitro data that I just showed you reflects into an in vivo scenario of improved HbA1c, better oral glucose tolerance area under the curve, and enhanced stimulated C-peptide. All of them arguing for the benefits of how icovamenib may be working in the context of therapies, including GLP-1. One other component in that context is the effect of this treatment on body weight and lean mass. And all of you are aware of the differences in the context of, what happens to fat mass, what happens to lean mass, and we're all aware that some of these individuals lose fat mass and also lose lean mass. And when they go off therapy, they put back fat again. So in this context, you can see that in this particular model, there is a significant loss of body weight in the presence of icovamenib and semaglutide. The lean mass composition is maintained or higher in the presence of icovamenib, and the fat mass composition again is beneficial. So overall, the ability of icovamenib in the presence of semaglutide to preserve lean mass and to make certain that the body weight is regulated in a way which preserves lean mass is an important observation. So we think that these are very exciting studies, and we are looking forward to how we can translate to the human, and that's where I think I'm going to hand over my slides to Juan. Just to give you a summary, I showed you that icovamenib promotes beta cell proliferation, highlighted microtissues in a glucose and dose-dependent manner, and the glucose-dependent manner is an important component here. In combination with GLP-1 receptor agonists, icovamenib enhances the response islets to semaglutide and tirzepatide. In vivo data argues for combination therapy with GLP-1 receptor agonists to improve glycemic control and, importantly, body composition. And so here, Juan will carry on to you. Thank you for your attention.
Wonderful. Thank you, Rohit and Steve. I'll mention that when we've looked at the prevalence of these severe insulin deficient patients, it ends up being about 15 million people in the US and Europe and over 40 million in East Asia and Asian countries. So it's quite a big population. And I think, for us clinicians, we definitely see these patients in the clinic, think they may have type 1 diabetes. They respond very poorly to non-insulin therapies. And I think we could make a big difference in that patient population. And Rohit, thank you for going over so carefully the mechanism of action, because it'll pertain to what I'm going to show here. Again, the beta cell proliferation you see, but also the increase in expression of GLP-1 receptors. So what I'm going to go through is the phase 2 study, top line data at week 26. So this is a trial on people with type 2 diabetes who were poorly controlled at baseline, A1C over 7%, with a BMI of 25 to 40 kilograms per meter squared, and they were treated with up to 3 anti-hyperglycemic agents. So sulfonylureazole and insulin were excluded in these patients. And you can see 3 arms. So arm A was 100 milligrams of icovamenib once daily for 8 weeks. Arm B was 100 milligrams daily for 12 weeks. And then arm C was 8 weeks at 100 milligrams and then escalating to 200 milligrams daily for the final 4 weeks. So very importantly, as we mentioned before, this is not chronic therapy. So at week 8 in arm A and week 12 in arms B and C, icovamenib was stopped. Patients continued on their background therapy, and the primary endpoint was a change in A1C from baseline to week 26, and that's what I'll show. We are following these patients, so this is an ongoing study out to week 52. We clearly want to see the durability beyond 26 weeks as well. I will mention that prior to locking the database in the statistical analysis plan, we proactively set up an analysis looking at these subgroups in patients with type 2 diabetes. So we took all comers into this trial. And in fact, the BMI was over 25, so we probably missed some of the SID patients, but this was a pre-specified analysis, and I'll be going over specifically those data as we're going through this. These are the baseline demographics of these patients, and basically very well matched to baseline, kind of mean age 54. These were all patients with a duration of diabetes or a diagnosis of less than 7 years, so the mean duration of diabetes was 4.5 years thereabouts. A1C 8.2, and you can see that about anywhere from 2/3 to 75% of the patients were obese, and the rest of the patients were overweight, but well matched between the two groups. So if we look at the therapy of baseline, the majority of patients were on metformin monotherapy. You can see that, but approximately 20% were also taking an SGLT2 inhibitor, and about 10% on a DPP4 inhibitor, and 10% on a GLP-1 receptor agonist. And as a post-hoc analysis, and I'll show this, we were very interested to see what happens with icovamenib in combination with either selective GLP-1 receptor agonist or the dual agonist, GIP-GLP-1 agonist, tirzepatide. And interestingly, if we looked at what proportion of these patients fell into these four categories, if we look at the insulin deficient categories, you see here that it was around 40%. And this is despite the fact that all of these patients were either overweight or obese. Certainly moving forward, as we specifically study the severe insulin deficient population with icovamenib, we would drop that lower BMI category, make sure we're checking antibodies that they don't have autoimmune diabetes, and we'll capture more of these patients. But even in this group that were overweight and obese, approximately 40% of the patients fell into this insulin deficient or these insulin deficient categories. So this is the hemoglobin A1C change. You see on the x-axis the time in the study, so out to week 26, the change in hemoglobin A1C on the y-axis, and the three arms. So you see at the top in gray is placebo, so no effect there. We treated again for 8 or 12 weeks. So the shaded area on the left is the treatment period with icovamenib. After 12 weeks, icovamenib is stopped. Background therapy is continued, and we saw particularly in arm B, the 100 milligrams once daily for 12 weeks, a very robust response in A1C. And again, this is 14 weeks after the final dose of icovamenib. And I can tell you as a clinician, if we pull off sulfonylureas or even GLP-1 receptor agonists, your A1C will come right back up by that point. So this is 3 months after discontinuation of icovamenib therapy. Now we're looking specifically at the severe insulin deficient patients from the three arms. This is three arms combined, A, B, and C. Again, 12 weeks of therapy, and out to week 26, it appears that the A1C reduction has not plateaued at week 26. And as I mentioned before, we're following these patients until week 52 in this trial, and you can see there was really no effect in the placebo-treated patients. Slight increase in A1C as we might expect. Now we're looking specifically at arm B, where we found the greatest efficacy. So 100 milligrams once daily for 12 weeks. Again, 12 weeks of therapy, come off the icovamenib, and you see a very nice reduction in A1C of about 1.3% from baseline and slightly below 1.5% when corrected for placebo, and again, does not appear to have plateaued. We conducted meal tolerance tests in all these patients, so we were checking for glucose, insulin, C-peptide as well, so stimulated C-peptide here. This is a baseline, and just to sort of state the obvious that those, if you look on the far left with severe insulin deficient diabetes, had the lowest C-peptide at baseline, and those with severe insulin-resistant diabetes, the highest. I don't have time to show it now, but if you look at the HOMA beta, a marker of beta cell function, those with severe insulin-deficient diabetes, it was somewhere around 45 or so. So it got kind of 45% of their beta cell function. Whereas those on the far right with severe insulin-resistant diabetes, it was over 250. So these patients are really hyperinsulinemic. We wouldn't expect as much of a response with icovamenib in those patients that are already hyperinsulinemic. They need to lose weight and improve their insulin sensitivity. This now is showing the change in C-peptide index, or the C-peptide over the glucose, and now we're looking at the stimulated C-peptide, so the area under the curve from the beginning of the study to week 26. And basically what this is showing is that in the insulin deficient groups, which are on the top, the SID and the MARD, the severe insulin deficient diabetes, the mild age-related diabetes, you're seeing this persistent increase in stimulated C-peptide. And again, at week 26, this is 14 weeks after therapy has been stopped, and really on the bottom, no effect in the two insulin-resistant and the obese phenotypes or subgroups. And this is what we saw in C-peptide here, and we see this 53% increase over time in the patients who have severe insulin deficient diabetes. Again, out to week 26, from baseline, a 53% increase in the C-peptide index, and half of the increase, though, is occurring after icovamenib is stopped, so from week 12 through week 26. And very importantly, and this really validates the mechanism of action, this correlation between the improvement in A1C and the improvement in C-peptide. So is A1C, the very nice correlation here between the degree of A1C reduction and the degree of C-peptide increase that was seen in these patients, really validating the mechanism of action that the C-peptide reduction is, or I'm sorry, the A1C reduction is due to an increase in beta cell function. Now, I mentioned that we did a post-hoc analysis, and these were our patients who were on GLP-1 based medicines at baseline. Most of these patients were on semaglutide. There were some on dulaglutide and tirzepatide as well, but it's a relatively small number. But these are people who were failing or not doing well on at least 3 months of stable GLP-1. Most of these patients were actually on for greater than 6 months. And you see very nice improvements in A1C. So what's shown on the right is the change in A1C from baseline at week 26, anywhere from 0.7 to 1%. These patients, particularly the semaglutide treated patients, all lost some body weight. This was not a weight loss study by any means, but we saw very nice effects that are congruent with what we've seen with respect to GLP-1 receptor expression that's increased with icovamenib therapy. So this is a population we'll clearly want to do specific studies in as well. From a safety perspective, if you look at the top row, this is the incidence of adverse events. You can see on the far right, 26% of icovamenib treated patients and 28% of placebo treated patients complained or had an adverse event reported during the trial, so very well tolerated. There were no patients that discontinued therapy or discontinued the study due to an adverse event, and no deaths. And here we see some of the adverse events that were seen in greater than 5% of patients. So a slight increase in diarrhea, you see in nausea, but very small numbers. All of these were grade 1 events. And again, no one discontinued therapy or even had temporary holding of the therapy due to any side effects. And on the bottom, you see very few cases of aminotransferase elevations at these doses. So to summarize, 12 weeks of icovamenib therapy resulted in clinically and statistically significant improvements in A1C at week 26. And again, that was 14 weeks after the final dose. Improvements in glucose control were greatest in participants with insulin deficient type 2 diabetes, as would be expected. In arm B, which was 100 milligrams daily for 12 weeks, there was a 1.5% placebo-corrected A1C reduction at week 26, again, 14 weeks after stopping. And this is a dose that we'll assess as we move forward in the clinical development program. The change in A1C significantly correlated with change in stimulated C-peptide, validating the mechanism of action. And icovamenib was safe and well tolerated without clinically significant elevations in aminotransferases and with no treatment emergent hypoglycemia. That's important. This is the proliferation you see is glucose dependent. In these studies that Rohit has shown with the islets, in euglycemic conditions, you do not get proliferation, so we don't see overproliferation. And moving forward, our anticipated clinical development plan will be to look at a study specifically in insulin deficient type 2 patients and also in combination, irrespective of the subgroup, in combination with GLP-1 based medicines.